Hello everybody. Today's topic is use and misuse of albumin. First we will discuss physiological effects of albumin. Albumin is the natural protein that is produced exclusively in the liver in amount as high as 9 to 14 gram per day. The median half-life is 18 to 19 days. And the albumin is responsible for maintaining fluid balance between intra and extracellular space. Albumin is responsible for 90% of colloid osmotic pressure. In critically ill patients, the interaction between colloidal osmotic pressure and the albumin is very complex and is significantly affected by increased capillary permeability and precapillary escape. Several experimental studies have demonstrated that albumin metabolism is more complex. The endothelium is also protein rich, with the glycocalyx being a small layer consisting of glycoprotein, proteoglycans, and the glucosamines, positioned on the luminal side of endothelium. The glycocalyx performs an important barrier function in the blood vessels. It has been demonstrated that even at albumin concentrations as low as 10 gram per liter, the glycocalyx is preserved and prevents the fluid shift into interstitial space. Another function of albumin is its ability to transport many medications, vitamins, and amino acids. The albumin also has immunological effect. The role of cyclooxygenase derived icosanoid prostaglandin E2, that is PGE2, has an immunosuppressant agent in patient with the liver cirrhosis. The studies identified significant increase in the level of PGE2 in patients with decompensated cirrhosis. So the PGE2 impairs the innate immune response in attenuating the inflammatory reaction and inhibiting phagocytosis activity of macrophages. The infusion of albumin decreases the level of PGE2, which may reduce the risk of infection in cirrhotic patients. So this is the diagrammatic representation which shows interaction between endothelial cell, glycocalyx, albumin, and interstitial space. The current understanding of vascular barrier function in high pressure segment of vascular system includes intact glycocalyx. The intact glycocalyx barrier competence is preserved even at albumin concentration less than 10 gram per liter. The green arrow shows the colloidal oncotic pressure, keeping fluid in the vascular lumen, while the blue arrow demonstrates the driving pressure out of the vessel. The thin purple arrow shows the transcapillary fluid flow, which results from the complex interaction of endothelial cell, glycocalyx, and albumin. So we'll see SAFE study. According to this study, albumin is useful in septic patients. In traumatic brain injury patient, use of albumin increases the mortality. So there are two additional issues that should be considered. Albumin administration is associated with significant sodium load ranging between 100 to 160 mol per liter, depending upon the albumin concentration. And 20% of albumin seem to be safest preparation, while the hypooncotic, that is 4% preparation, should be avoided, particularly in patients with the traumatic brain injury. Now, hypoalbuminemia, generally defined as serum albumin concentration less than 30 gram per liter, is very common condition in critically ill patients. So hypoalbuminemia leads to increased capillary permeability with subsequent fluid redistribution from intravascular to the interstitial space. Hypoalbuminemia, regardless of underlying mechanism, is associated with increased morbidity and mortality. At this time, there is no clear evidence to support albumin replacement in critically ill patients with low serum albumin levels. Albumin use in sepsis. The SAFE study indicated that patients with the sepsis may benefit from the albumin replacement. A pooled analysis of all three studies, that is SAFE study, Albios, and the EAR study, identified improved outcome for patients resuscitated with the albumin. There is ongoing RCT in Germany, which is albumin replacement in septic shock. This study is currently recruiting patients with the septic shock. International guidelines for the management of sepsis and septic shock, surviving sepsis campaign, graded the recommendation for albumin administration in adult with septic and septic shock as a weak. Albumin and ARDS. In septic patient, hypoalbuminemia in the setting of ARDS is associated with the inferior outcome. Albumin has many other properties in addition to its effect in intravascular volume, including antioxidant activities and molecular transport. Clinical research had shown improvement in physiological parameters after human albumin administration with or without furosemide in patients with ARDS. The antioxidant effect of albumin is related to its capacity to bind iron and copper, thus reducing the availability of this component for a pro-oxidant reaction. Antimicrobial binding capacity has been shown to be decreased in patients with hypoalbumin. Albumin can also protect the microvascular and attenuate the increased vascular permeability by reducing capillary bed leakage. Finally, there is inverse association of albumin concentration with level of several pro-inflammatory cytokines. In preclinical ARDS studies, albumin attenuated lung damage by reducing oxidative stress and pulmonary inflammation. In hyperoncotic albumin, that is 20 to 25%, was associated with the renal dysfunction. Albumin improved oxygenation but did not affect the mortality in ARDS. Albumin has the ability to inhibit platelet aggregation due to structural similarities between the two. Therefore, in theory, albumin replacement may attenuate the coagulation cascade in ARDS when administered at right time and right dose. Albumin reduces lung edema, restores and maintains the glycocalyx integrity in experimental ARDS. Now, albumin replacement in cirrhotic patients. In patients with the end-stage liver disease, albumin is often used as both medication or volume replacement. The most supportive evidence for the use of albumin in patients with end-stage liver disease is available for fluid replacement after large volume paracentesis, for patients with hepatorenal syndrome, and for spontaneous bacterial peritonitis. Repeated large volume paracentesis in patients with the TENS ascites is well recognized first-line treatment modalities. Draining large volume of ascites may be associated with hemodynamic instability. In order to prevent severe hypotension, it has been recommended to replace 8 grams of albumin for every liter of ascites. In patients who are hemodynamically unstable or suffer from acute kidney injury, 8 grams of the albumin should be replaced for every liter of ascites, even if amount of paracentesis is under 5 liters. This is because kidneys require stable hemodynamic to preserve their function. In the ANSWER trial, overall survival was significantly higher in albumin group. The MATCH trial, which evaluated 196 liver transplant candidates, patients were randomly assigned to reduce midodrine, that is 15 to 30 mg per day, and albumin, that is 40 grams per 15 days, and the corresponding control patient placebos for 1. In contrast to ANSWER trial, the author did not find any difference in morbidity and mortality after 1. So the entire trial was randomized multi-centered evaluation involving hospitalized patients with decompensated cirrhosis who had serum albumin level of less than 30 gram per liter at the time of enrollment. The patients were randomly assigned to receive either 20% of human albumin solution for up to 14 days or until discharge, whichever comes first, or standard care. So, a total of 777 patients underwent randomization. Regarding kidney failure, infection, hospital mortality, there was no difference between the both the groups. Regarding spontaneous bacterial peritonitis, it typically appears in patients with cirrhosis and ascites. Due to interstitial ischemia, the mucosal surface and intestinal epithelial are damaged, resulting in the bacterial translocation to ascites. These patients require antibiotic treatment and not surgical intervention. So in 1999, Sort et al. Published a study regarding the use of albumin in the treatment of SBP. In this study, 126 patients with cirrhosis and SBP were recruited either to receive cefotaxime, that is cefotaxime in 63 patients, or cefotaxime and albumin in 63 patients. Cefotaxime was given daily and albumin was given at a dose of 1.5 gram per kg body weight at the time of diagnosis, followed by 1 gram per kg of body weight on the day 3. So infection resolved in 94% of patients in cefotaxime group and 98% of patients in albumin group. However, acute kidney injury developed in 21 patients in cefotaxime group and only 6 patients in albumin group. So, regarding hepatorenal syndrome, it is a serious complication in patient with cirrhosis and is associated with a high morbidity and mortality. It is characterized by circulatory dysfunction that exceeds the compensatory mechanism of kidneys, promoting vasoconstriction of vas efferent, resulting in decreased glomerular filtration. So the diagnosis of HRS is based on the following parameters. That is one, that is the presence of portal hypertension, and second, it is a diagnosis of exclusion. Means we should exclude all other reasons for kidney impairment. Now the stratification of HRS is included two types. Type 1, that is a rapid reduction of the renal function by doubling initial serum creatinine to the concentration of at least 2.5 mg per dl. And type 2, renal failure progression does not meet the criteria for type albumin and renal replacement therapy. The renal study was multi-centered prospective randomized trial comparing two levels of intensity of continuous RRT. Data from subgroup of the patient in this study underwent post-hoc analysis to evaluate the effect of albumin 20% or 25%. And author found that albumin treatment was associated with a more effective fluid removal. Albumin and post-operative patient. Plasma albumin concentration was repeatedly measured over 70 to 72 hours. So plasma albumin concentration decreased rapidly from baseline until the start of surgical reconstruction. The overall decrease in albumin continued until 1 hour after surgery, falling to 40% of initial value and was then stable for next 72 hours. So the pre-existing hypoalbuminemia would become more evident in this setting. Hypoalbuminemia has been shown to be associated with inferior outcome in surgical patients. So there remains uncertainty if low albumin plasma concentration itself is a biomarker for poor outcome and if albumin should be corrected to prior surgery. So albumin, 4% albumin is the hypoosmolar and should generally be avoided, particularly in patients with intracranial pathology. The highest quality evidence exists for albumin is patient with cirrhosis, particularly for the treatment of SBP, HRS, and the large volume paracentesis. Patients with the cirrhosis and hyponatremia who are scheduled for liver transplant are at risk of osmotic demyelination syndrome post-operatively because of rapid rise in serum sodium associated with use of large volume of albumin solutions. So albumin formulation with high sodium concentration should be avoided in this subgroup of the patient. Now, for the patient with sepsis and ARDS and undergoing ECMO, the evidence for albumin therapy is not robust enough to allow for general recommendation. The albumin should be considered when hemodynamic stability cannot be achieved with crystalloid albumin. Thank you.